My pleasure to introduce the chairpersons for the next session, Dr. Ramasubramanian and Dr. Kumudini Jayasinghe, for the keynote speech on emerging and re-emerging infections. Please join me in welcoming them.
Good morning, everyone. Welcome to the first keynote speech of SIMCON 2024. And I'm Dr. Kumudini Jayasinghe, and my co-chair is Dr. Ramasubramanian, the president of SLCIM. And I have pleasant task of introducing the speaker. Dr. Ramasubramanian is a specialist in infectious diseases, adolescent and adult vaccination, and travel medicine. He is currently the head of the Department of Infectious Diseases, HIV and Tropical Medicine at Apollo Hospitals, Chennai. And he is also an adjunct professor of infectious diseases at the Sri Ramachandra Institute of Higher Education and Research. I will invite Dr. Ramasubramanian to deliver his talk on emerging and re-emerging infections.
Thank you very much for the kind words, chairpersons, and good morning to all of you. It's a pleasure to be back here in Sri Lanka, a place I love, though it is just an hour away from where I stay in Chennai. I've been asked to talk to you about emerging and re-emerging infections. And this is something which I feel all of us should know really well, because this is the elephant in the room. If you look at emerging infections, they are infections which have recently appeared in the scene, and either in terms of an increasing incidence or in terms of increasing geographical distribution. So emerging infections is clear, but what about re-emerging infections? To give you an example, do you know who this gentleman is? Those who are familiar with the cinematic scenes of India, this is how Shah Rukh Khan was when he entered the film Dum. And this is the re-emergence of Shah Rukh Khan. So this is how re-emerging infections look. When they come in, they are quiet, they appear on and off, but then suddenly they come in with a bang and create a scene. To give you a little bit of history, this was in 1918, the influenza pandemic. It was at Fort Riley. An army private reports to the camp hospital just before breakfast on the 11th of March, complaining of fever, sore throat, and headache. By noon, the camp's hospital had dealt with over 100 ill soldiers, and by the end of the week, the number had jumped to 500. Very soon, they started converting their barracks to hospitals. Beds were lined up. It was filled with young, fit, healthy soldiers who had suddenly come down with a bad case of flu. They ran out of beds, and they started putting beds outside the barracks. And this was the beginning of the pandemic, the Spanish flu pandemic of 1918. And when it ended about a couple of years later, more people had died in this pandemic, now looking back, than those who were killed both in World War I and World War II put together. Almost 50 million people died at the end of the Spanish flu pandemic. So this is how emerging infections strike. This is a disease with a rate of infection that has increased in the previous 20 years, and it could increase in the near future. They account for almost 12% of all human pathogens. They are caused by newly identified species or strains that may have evolved from a known infection. We had the coronavirus, for example, the SARS-CoV, COVID-19, which had evolved from the MERS, which had evolved from the SARS of 2003-2004. So they can evolve genetically. They can spread to a new population or an area undergoing ecological transformation. For example, the chikungunya outbreak, which started somewhere in Africa and Madagascar, slowly through the Aedes albopictus mosquito species, which traveled to India, then invaded the whole of Southeast Asia. So this is a new development, even though it had been documented in India in the 1950s and 60s. The disease went on to involve the whole of Southeast Asia. And what's more worrying is the fact that adverse synergistic interactions between the emerging diseases and other infectious and non-infectious conditions leading to the development of novel syndemics are of growing concern. But the emerging infections is not new. It is not the SARS or the Spanish flu. This started even way about 2,500 years before. When the plague of Athens hit, we still don't know how many people died at the time. Subsequently, it was about 1500 years ago, the Justinian plague, which killed almost half of the world population. Almost 50 million people died during the Justinian plague. Subsequently, the Black Death in the 14th century, another 15 million, which killed a quarter of the world population. This carried on. In fact, the smallpox epidemic, which was carried by the Spanish conquistadors, that involved almost the entire Aztec civilization, bringing the civilization to an end in Mexico. We have subsequently the cholera plagues in the 19th century and the Spanish flu in 1918. By the 1950s, antibiotics like penicillin, streptomycin, and several others were in the pipeline. We had found a treatment for tuberculosis. We had come up with a polio vaccine. So the Surgeon General now famously said that it is time to close the chapter on infectious diseases. But subsequently, we have seen we were hit by the AIDS epidemic, which has so far killed about 42 million people. And now the SARS, COVID-19, which has killed almost 7 million people. So this is to go on. This is not something which is ending. This is to go on with us. And this map gives you an idea of the various emerging and re-emerging infections. Now, it has been shown that as human societies increase in size and complexity, it creates a lot of ecological niches where the genetically unstable viruses and bacteria can occupy. It is believed that some of these infections have a dead end in the human host. In other words, for example, you get West Nile virus. The West Nile virus has expanded to involve almost 30 species of mosquitoes, which are the vectors, and then go on to involve almost 150 species of bird population, which can get West Nile virus infection. But similarly, when a human gets it, it's a dead-end transmission. So why do viruses move on to another species to cause this? It is still not clear, but probably they lose their fitness quotient to develop some adaptable flexibility in their growth. It was Richard Dawkins who said that, the biologist from UK, who said that in the genetic competition which happens in the viruses and bacteria, man is just a survival machine. If you look at the definitions of the various the entities we have discussed so far, a newly emerging infectious diseases is a disease recognized in humans for the first time. The HIV/AIDS in 1981, the Nipah virus in 1999 in Malaysia, then subsequently the SARS, the MERS, and the COVID-19. We have re-emerging infectious diseases, those that have historically infected humans but continue to reappear either in new locations. The West Nile outbreak, the occurrence of the Zika virus epidemic of 2015, the MRSA, for example. Then we have the deliberately emerging infectious diseases. Now, these are what we refer to as bioterrorism or biological warfare. This happened way back in the Crimean War of, even before that, actually the 1346 war, where in the Crimean port of what is now in Ukraine, they used to catapult corpses of people who had died due to plague into the fort, into the city, so that it could spread the plague inside the city. And then during the 18th century, the British soldiers gifted the Native Americans blankets used by the smallpox victims, which were contaminated with smallpox. They gave it as gifts so that could cause smallpox in the Indian communities. So this is all biological warfare. Subsequently, we have seen in 2001, where anthrax spores were mailed to several senators in the US, which killed almost 5 people. That was an intent of biological warfare. And lastly, the accidentally emerging infectious diseases. There was a huge, breakdown of biological weapons making factory in Ekaterinburg, which is now in Ukraine, in Russia, where accidentally anthrax spores were introduced into the environment, which traveled almost 4-5 kilometers and killed over 100 people. So these are all the ways in which infections can strike and restrike. But what basically happens is an interaction between the agent, the host, and the environment. If you look at the agent, there is a constant genetic evolution which happens in viruses. This is a form of evolution which is undergone by the various viruses and other microorganisms. So there is a lot of diversity, there is evolution and change. This increases the infectivity of certain species, it increases the transmission of certain species. So that is how they evolve. And co-pathogenesis can also happen with regard to the host, with regard to the agent. Then you have the host. The host, sometimes the virus skips from one species to another. This is called the species switching. Again, why does this happen when it is happily spreading in one host? This is because of both the evolution of genetic mechanisms in the agent and also due to the human behavior. It has been seen that a lot of times, I'll give you the example of the Nipah virus in Malaysia in 1999, there was a lot of deforestation. So the fruit bats which were in the jungles were running out of space and food. So it traveled towards human establishments where people had a lot of pig farms. Adjacent to the pig farms, they had fruit orchards. So the fruit bats which came into the human settlements started, colonizing the area around, and after eating the fruits, the droppings which contained the Nipah virus subsequently entered the human species. So there was a close animal-human interface which caused the occurrence of this disease. So it is not just the pathogen, it is also the behavior characteristics of the humans. Lastly, the environment. Environment increases risk of animal exposures. There is environmental degradation, as I said, deforestation, which causes the animals and the virus, the species vectors to move towards human settlements. Changes in climate and weather, which increases not only the pathogens, but also the vector status. Economic development and land use, poverty and social ills. Wars and famines are very closely associated with the occurrence of epidemics. Lack of public health infrastructure and lack of political will. Lot of times it has been seen that this progress of epidemics actually is associated with human behavior. For example, the cholera outbreak which happened in India, which went to Europe and then subsequently to the US, it was seen that the spread of the epidemic was associated with the travel patterns. It was initially through coaches and then through ships from Europe to the US. So whenever in winter there was less of ship travel, the outbreak came down. During summer, when it increased, the outbreak went up. So there was a lot of connection. Similarly, the plague was also associated with coach travel. The flu, which happened subsequently in 1958, initially was associated with ship travel, and then 1968, it was associated with air travel. Same thing with SARS also, which happened in early 2000. This is related to the type of organisms or how the organism spreads. They have been categorized into 3 types, but more importantly, it is related to the mechanism of transmission. You'll find that those which are transmitted through the respiratory route, like influenza, coronavirus, measles, rhinoviruses, can spread more rapidly. So the occurrence of an outbreak is much more rapid with this compared to those which are transmitted through the gastrointestinal route, the cholera, norovirus, which are more localized and travel less frequently from one place to another. Of course, there are other modalities of travel, including direct and vector-borne travel, which also have different mechanics. From the year 1940 to 2004, almost 335 outbreaks of emerging diseases has been shown. And what is surprising is the impact is always greater. Almost 60% are those due to zoonotic infections. So infections like MERS, SARS, flu, West Nile, plague, and sporothrix, they are all mainly animal infections which subsequently come to humans. So the 60% of infections which are emerging and have a more stronger impact are all of zoonotic origin when compared to other infections like smallpox, Staph aureus, candida, or blastomyces. This species switching, as I said, the evolutionary changes which happen in the genetic mechanisms of these microorganisms subsequently lead to a switching of species. This could be, as it is written here, as a steep fitness valley or a shallow fitness valley, the ability to jump species. What happens sometimes once they jump species, they become dead-end infections in these cases. Very strong example of rabies. Rabies, once man gets, eventually ends with man. It doesn't go beyond, it doesn't transmit between humans unless it's an organ transplant. But this probably plays a very big role in the transmission of infections. This picture very clearly shows that in stage 1, when you look at the 5 stages through which pathogens evolve to become human infections, stage 1 is those which are seen only in animals, and when it reaches man, it inevitably ends. You have infections like Ebola, which are again primarily zoonotic, which spread to the human host, and very briefly, in very close contacts, the infection can spread. Then you have conditions like dengue, which is able to spread from one person to another through the bite of mosquitoes, taking it far and wide. And of course, other infections like HIV, which once comes into human hold, it stays in the humans, very unlikely to go back to animals or be transmitted by animals. So these mechanics are very important in understanding the occurrence of emerging infections. If you look at the factors of emerging infectious diseases, I'm not talking about obesity, I'm talking about infections. There are various factors which have been noted. Microbial adaptation and change. As I said, the Zika virus evolved suddenly to become more infectious and thereby causing the 2015 outbreak, which caused a lot of teratogenic malformations in children in South America, Central America, and elsewhere. Human susceptibility to infection. The monkeypox outbreak, which is recently caused, we found that those who had had the smallpox vaccination as a child, I have had a smallpox vaccination, so I'm quite well protected from monkeypox. So the human susceptibility to infection due to various reasons also plays a role. The climate and weather, which I will tell you subsequently. Changing ecosystems, how the usage of water, the agriculture, the storage of ecosystems of water, all can impact the emergence of infectious diseases. Human demographics and behavior change, classic example of HIV and AIDS. The behavior is what caused the problem. Economic development, travel, breakdown of public health measures, poverty and inequality, famine, war, and most importantly, a lack of political will and an intent to harm. These are various examples which we have come across in the recent decades. MERS, SARS, and SARS-CoV. Lot of it had to do with a close animal-human interface, typically seen. There is a breakdown of this in countries like of the Far East, China, where there is a very close contact of animals with humans. We have the Zika and the Lassa virus, which both in South America and Africa spread through vectors. We have Ebola and Marburg. Again, how the Ebola has somehow become enzootic, in the sense that it is transmitted to humans, but still remains to stay as a very localized area, except in the recent past where there were few cases noticed in the US and Europe, and certain other viruses. But there are also unconventional agents. We have Candida auris. This has been recently renamed. It's called Candidozyma auris. I just came to know about it a couple of days ago. So the fungal taxonomy is changing very rapidly. This behaves more like a bacteria. It is highly resistant. It stays in the environment for long periods of time and also difficult to treat. We have Elisabethingia anopheles, bacteria which is seen typically involving elderly patients, immunocompromised patients with several comorbidities, can cause a respiratory infection. In fact, it can present like an acute flu-like syndrome. It is transmitted. It has also been documented in the Anopheles mosquito. The connection is still not clear. The MCR gene associated with resistance to colistin, first identified in China in 2015, also has had various. In fact, we are seeing more of this in India nowadays with regard to Acinetobacter. The Lone Star tick, which is seen in the US, suddenly proliferated recently, and there was an increase in certain viral conditions which have been newly documented. The Bourbon virus, the wetland virus, and also ehrlichiosis. So these are all infections which are locally seen in places where there is a high incidence of the Lone Star tick. And of course, the multi-drug resistant TB, which is a huge problem in Eastern Europe and also in India now. If you're looking at environmental outcomes of climate change, an increased temperature, the greenhouse effect, the increased pollution, all of which expand the occurrence of certain pathogenic reservoir and also associated with certain human behaviors which can cause increased occurrence of infection. The airborne viruses, the food and floodborne viruses, the temperature, humidity, air pollution, all of this impact the occurrence of infections and the ability of humans to get these infections. So if you're looking at approaches to mitigate the spread of infectious disease. We need to tackle all of this, which will include surveillance, hygiene, sanitation, public health, and timely detection and diagnosis. In fact, it is now the stress is on what is called the WASH. Water, sanitation, and hygiene is becoming a huge aspect of the One Health strategy of the WHO to look into this. Can we expect more of emerging infectious disease outbreaks? The answer is a resounding yes. Pathogens keep mutating, which means it increases transmission, more effective transmission and pathogenicity. Globalization, the world has now become very small, so spread from one place to another is very, very easy. War and conflicts, we are seeing more of war. What is happening earlier was limited to the Middle East. Now we are finding it in other places also. The Ukraine, Russia war, the Israel, Lebanon. Human population growth with encroachment into the animal ecosystem is a huge problem. Climate changes, I think there is no correct answer for this, and an increased demand for meat and animal products. We saw that in the late 1990s, the mad cow disease which afflicted the UK was an example of this. So all this are definitely bound to increase the occurrence of emerging infections. These are here to stay. We are likely to see more of these infections. And if you're coming out with some sort of solutions, the main approaches to keep in mind are we need new diagnostic tools. We need to understand that the increase in human exposure to bacterial pathogens will occur and the emergence of more virulent bacterial strains is definitely on the cards. So the approach should be a multifactorial approach. Starts with genomic surveillance, epidemiological analysis of what is happening. So surveillance plays a huge part. We also need subsequently early diagnostics, which include point-of-care testing, biosensors, geoinformatics, mobile application tracking, and simulation models. All these are very important. We also need to have genetic sequencing. Genetic sequencing, which happened with the SARS-CoV, gave us a very early idea of what was happening, and we were able to rally and come up with answers, vaccines, to stem the problem of the emerging infections. All this is very important. The omics, which we refer to as genomics, proteomics, metabolomics, and transcriptomics, have to be integrated if you are going to come up with an answer, and throw in artificial intelligence to this. That is where probably the answer lies. But there are several gaps in the directions and prospects. There is a lack of animal models. We are not able to get animal models which can help us identify and replicate the infections in animals so that we can learn more. The FDA has a 2-animal rule where one animal is not enough. You have to replicate it in 2 animals, different species, to show that it actually the experiments work. How can we extrapolate human clinical conditions from animal models? Very questionable. We need novel sensitization strategies. We need clarification of correlates of disease protection. I will tell you in the subsequent slide. The understanding of disease mechanisms, understanding subtypes and variants. By the time we came up with an answer for COVID-19, the virus had already mutated to Omicron and other such lineages. The disease severity, comorbidity, and sequelae in humans is different from what we would see in animals. And lastly, emerging technologies for prevention and control of infectious diseases is still very, very localized to certain developed nations, and this is a huge challenge. This is a study we undertook during the COVID times, where it found that there's a positive correlation between the IgG and the neutralizing antibodies. The level of neutralizing antibodies gave a level of protection, and if you increase the neutralizing antibodies in a person, it increases the interferon gamma response and had a negative correlation between viral loads and clinical disease. So we were able to replicate this in animals and thereby showed that this is probably the answer. But most importantly, we need better surveillance. What is needed is cooperation and communication. The whole thing is based on technical sharing, technology sharing, information sharing, united management, expert sharing, and resources sharing. And once we are able to share the resources of surveillance, we share the technology and the resources, that is when we will be able to come up with an answer. But there are a lot of challenges to this. We have a lack of accuracy in data. Unfortunately, even the WHO surveillance sometimes can fail. There is fragments in management, scarce international cooperation due to various vested interests. All this impact on the proper identification. But most importantly, it is communication, which is the problem. Why isn't COVID affecting you people? We don't have TV. So it became a joke during times of COVID that the more the media spoke about a condition, the more the cases which were detected in that area. So Africa actually had very little of COVID when compared to Europe or the US. So all this played a role. And if you're looking at mitigating the spread of these infections, you can see that between the natural host, the intermediate host, and the humans, you need to block the infections, and probably genetic sequencing and coming up with vaccines would be the correct answer. But even here, how many vaccines will you have? In India, we had 2 doses. Health workers had 3 doses. In the US, I've seen people who have taken 7 or 8 doses still. Every 6 months, they promptly go to the pharmacy and get a shot. So how many of them are actually needed? We don't know. And in spite of all these, there are newer emerging infections. In the US, we have the Bourbon virus, the Heartland virus. Both of them are tick-borne viruses spread by ticks, do not respond to doxycycline, only supportive management helps. One is from Kansas, the other is from Missouri. The Keystone virus has been identified in Florida, associated with the Aedes Atlanticus mosquito, probably a vector-borne virus. In Central and South America, the Oropoche virus is now really on the rise. It was detected in 1961 in Trinidad, but recently this resembles dengue, but can have features of encephalitis and has also been shown to be teratogenic in pregnant women. The Chapare hemorrhagic virus in Bolivia is a hemorrhagic virus, again believed to be transmitted through person-to-person contact or through infected rodents. In Europe, the variegated squirrel Borna virus encephalitis causes a limbic encephalitis transmitted by the variegated squirrel, which is originally from Central America. In certain breeders in Germany who handle this virus, squirrel, the virus caused a problem. In Asia, Alongshan virus, similar to influenza, and the wetland virus disease, which is again tick-borne, is also seen. So we need a One Health approach. Tackling human health alone is not enough. We need to look at animal health and the environment through analysis of various newer techniques and genetic mechanisms. And I said all the omics needs to be taken into consideration. The integration and sharing of data is probably the answer. So I leave you with this. If you're looking at emerging and re-emerging infections, I started saying it is the elephant in the room. I'll go on to say that this cartoon shows, if you observe carefully near the hill, behind the large tree, you can see a lion, but the lion is very much near us. Thank you.
Thank you very much for your enlightening talk. And the keynote speeches, the 2 keynote speeches in this whole program. So one is for emerging and re-emerging infections. So everybody would know that emerging and re-emerging infections are a problem to us. It had been emerging, and not only communicable diseases, not only non-communicable diseases. Communicable diseases are also a problem to everybody, the clinicians these days. And I thank you very much for your talk. And we can allow 1 or 2 questions from the audience.
How does one health approach in India? I just came after Health Ministry sort of workshop on this. What is your sort of contribution in the sense, I mean, how do you sort of approach in India? Do you have a proper setup in there?
No, unfortunately, even though I think the handling of COVID was actually very well appreciated in India, was very well appreciated because it was a unified approach with the government. Initially, the lockdown appeared draconic, and in retrospect, maybe they needn't have done it that well. But towards the end, the way they managed the vaccine distribution, the initiation of vaccines, the free vaccines all over, that was very, very well conducted. But the problem in India is still the surveillance. There is no united surveillance where you can collect the data. Probably Kerala is one of the most developed of states which detects all the outbreaks. Whether it happens in Kerala or whether they detect it early is still questionable. Whether it was Nipah virus, whether it is the primary amoebic meningoencephalitis, where several cases have been documented in Kerala, we don't know. But as a machinery, the state government machinery and the private machinery work together, and it has done very well. But I wish we could replicate that in other states. But surveillance is the problem in India.
One more question.
So let me have the privilege of having that question as well. Is it basically getting people into the surveillance system, or is it the technology that you have problem with both?
Both. For example, we have large outbreaks of Japanese bee encephalitis viruses in Uttar Pradesh and Orissa and Madhya Pradesh. These are very backward states where getting the information, diagnosing it, it's all a syndromic diagnosis, which unfortunately will not work. You need to prove it. The system is improving, but I think it is scarcity or access to diagnosis which is a main problem.
Okay, thank you very much. And for the interest of time, we will conclude the keynote speech session. And you can listen to him tomorrow on tackling the resistant organisms, how to deal with. So that talk will be on tomorrow. So we'll conclude these sessions. Thank you very much.
Before we conclude, may I invite my co-chair, Dr. Surangamanian, to hand over the certificate to Dr. Ramasubramanian.
Thank you, dear sir, for sharing those valuable insights. And thank you, dear chairpersons, for moderating the session.